okay, it's not coming. Yes, hopefully if they connect it, yes.
Hello, Assalamu alaikum. Okay, welcome to all seniors and colleagues. We are starting the pediatric session, and the first lecture is of Professor Muhammad Muharram Inan, that is from Istanbul, Turkey, and the topic is cerebral palsy, hip or knee and foot problems. We are starting with the first topic, the congenital patella dislocation.
Is there any control? Sorry for this problem. Thank you again, and welcome to here. That's the very rare problems. This is the congenital patellar dislocation. Is the we have some solution for that. Yes. Just the why we are doing why we have problems for the after the dislocation of the patella, because of the extensor mechanism is lacking, then the stability is losing, and the patient is unable to walk and delayed walking, and sometimes we have a difficulties for the using the orthotics. In the historical things, there are lateral release, medial plications, medial transfer to the patellar tendon, and posterior release, and combination of these. We did a study with, we used the techniques, they combined them for the many techniques, and we did a combined techniques. This is a, sometimes people is saying that super knee procedures, but this is a poly called this name. But according to me, for this solution, we need a tensor fasciae latae and lateral release of the patella and the vastus lateralis, and we need some transfer to fasciae latae to the patella and the we need a rectus zephylasti sometimes, and femoral osteotomy. We don't need all of them all the time, because we are going to step by step. The last steps is the osteotomy. We have the 11 patients, and Down syndrome, meningomyelocele, Prader-Willi syndrome, and cerebral palsy. The surgical technique is when you look at the intraoperatively, there is a patella is on the lateral. Never fix it, and usually they staying on the lateral position. Some patients has the articulation of the patellar surface on the lateral border of the femur. Then we are doing arthroscopy. If we are thinking that there are some problems intra-articularly, if you think that there is some ACL problems, meniscal problems, cartilage problems, this is also the quickly we are going there, we are searching, evaluating this knee joint, and this is our incision, on the lateral incision coming to the just patellar tendon attachment. And we are harvesting the fascia lata first and dividing to two parts, anterior part and the posterior part. And we are releasing the vastus lateralis from that point. Just attaching to the rectus side. And you see here that after the releasing the patella lateral release, still there is some lateral subluxation. Patella is coming to the lateral side. Then we are going to second incision. We are going to medial parapatellar incision, just 4 to 5 centimeters. And we are taking the anterior part of the fascia lata under the patella and taking to the medial side of the patella, just like a anterior cruciate ligament for the anterior stability. Then we are doing this rectus zephylasti. Many of the patients require this zephylasti. Without this zephylasti, you feel that patella is never keeping the place, that it goes to lateral. And in that stage, you see that our anterior part of the fascia lata, I think there is no laser pointer, sorry for that, but I am not showing this, there is no laser pointer. This here. Here is okay, but anyway, this is if you look at the anterior part of the fascia lata, we are going to the semitendinosus muscles, and we are taking from the posterior side the anterior and coming back to patella and suturing the patella. When you look at the medial side here, we are taking the fascia lata here and turning it from the ancient muscles, and we are coming to patella.
Hello.
That's okay. Then if you look at the other part, posterior part of the fascia lata, we use this part of the fascia lata to construct the lateral side of the ligament, because it acts like a lateral collateral ligaments. That's why we are suturing again 1 or 2 times is suturing on the lateral side of the joint, the tibio-talar joint. And you see after these procedures, that's just before the lateral reconstruction, it is okay. Yeah, sometimes you see that there is the femoral anteversion is too much. Then even you are doing all this kind of the surgeries, but patellar surface is looking the patellar surface of the joint, looking to the internal or external. You have to correct it. You need an osteotomy at that time. And if you look at this case, this is very old. Then the patellar subluxation. We are harvesting the tensor fascia lata and dividing to the 2 parts. And we are going to the medial, and on the left down, we are taking the fascia lata from lateral to the medial incision, and we are rerouting this fascia lata around the semitendinosus and suturing the medial patella. This is the stabilization for the medial patella. And this is the reconstruction of the lateral collateral ligament you see here. Sometimes it works, sometimes it doesn't work, I don't know. Please forward then. Can you click the videos? Because yes. I hope we can finish this presentation end of this story because they will present instead of me. That's because it's continued. You can go back. Yeah, on the yes, that's the video. Yeah, after the surgery, patella is going very good. Then if you have any lateralization in the follow-up, we are going just three of the three knees need the medial plication again. There is no resubluxation, but there is a lateralization of the patella. That's why we go to the medial plication the second time for the revisions. And here, that's the older age. You can see this is the unstable knee. And after the surgery that's the much better because this is just the construction of this knee joint, like anterior stability, lateral stability, create some kind of the stability at the knee and stiffness. That's I think this is our minimum follow-up time, and we are continuing to operate these kids. We have 2 more kids in that month, and just 3 of them need the osteotomy. And I want to give the summary for this presentation. Lateral release, tensor fascial lateral transfer, and rectus staphylostomy and lateral collateral reconstruction. You have to do that. Sometimes you need an osteotomy, also these kids. Thank you very much. Then hopefully I finish. That's for the second talk, then please continue. We can fix my presentation there.
Okay, for the next talk, I will invite Professor Irfan Mehboob, and the talk is on missed fractures of the children. So there is some problem with the loading. So I will invite Professor Muhammad Amin Chunai for the current status of the clubfoot services in Pakistan.
हुआ हुआ है सर ओके जी बिस्मिल्लाहिर्रहमानिर्रहीम रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली I'm going to talk about the current status of club foot services in Pakistan. I work at the Indus Hospital, Karachi, which is now actually a network of hospitals. this is the current status of clubfoot, was actually, I should say. More than 5 million babies are born annually. That means that approximately 7,500 will be born every year with clubfoot. And this is that cohort that we need to catch, and we don't really want any of them to come late and be then treated as neglected clubfoot. So this was the situation in 2011, except for maybe a few cases: no treatment, neglected clubfoot, late presentation. A lot of surgical procedures were being done, from minimally invasive to extensive releases. Kites methods was being practiced. Some people were already had started to do Ponseti method treatment, but there were and still are financial, technical, and equipment constraints. We started it as a programmatic approach at our place in 2011 and 12, and obviously that entails having a systematic approach, planning for the population demographics, standardized treatment protocols, and making sure that we have long-term follow-ups so that we don't have to get recurrences and relapses that are left untreated and cause problems later on. As I said earlier, we were doing clubfoot from 2007, the Ponseti treatment from 2007 at our hospital. But actually this program, which is called Pehla Qadam, which means first step in English, we started this program in 2011 when we got a donor whose own child had clubfoot. He was in the United States in the Silicon Valley. He took his daughter to Iowa where it was treated, and then he got involved with the Ponseti treatment and finally landed up being a board member of the Ponseti International. So what was our mission? Was to create public awareness among clubfoot and its optimal management, eliminate untreated clubfoot in Pakistan, and capacity building for Ponseti treatment at the national level. So I'm just going to show a few slides about Indus program, and then I'm going to talk about the Pakistan program. So programmatic management, Pehla Qadam clinics, Ponseti method of treatment was what we planned and we started. So we went through this stage of pre-program planning, which was community engagement and focus group discussions, developed the different enrollment forms, developed the educational material. We did training of the health workers, especially the community health workers and the lady health workers who are out in the community in our vicinity, so that they would report to us any child who was born with clubfoot, and then refer them to us as well. So few months later, we started the screening and the enrollment. At each visit, Pirani scoring was done, photographs were taken of the feet, standard Ponseti casting, tenotomy if needed, and braces. The most important thing was the data entry into the International Clubfoot Registry at Iowa, and then the data analysis, monitoring and evaluation, and financials and their reportings. So we all know that, so just the whole sequence here. I'm not going to waste time on this, but as I said, important thing was information about the clubfoot and the Pehla Qadam program at the hospital and in around the city, plaster care and removal and handling of the braces. We collect all the demographic data for all the patients that come to us for the first visit, and after that, each visit photographs are taken and Pirani scoring is done. And the data is entered into our hospital management information system, which is because our hospital is totally a paper-free hospital since 2007, and all of that is then also uploaded into the Clubfoot registry at Iowa. So the team roles are there. Health workers, there's a manager who looks after all the programmatic aspect. The orthopedic doctors do the scoring and the casting and the tenotomies. Then we have the technicians to help us, and then there are some people like myself who don't do anything. So currently with the Interest Health Network, these are the clinics that we are running across Pakistan. So we have in Karachi, in Badin, in Gawadar, Kankot, then in Punjab, in Muzaffargarh, and in Lahore. Okay, so this is the summary of the treatment, and I'm going to talk about it later on, so I'll just skip this slide again. So this is a 4-year treatment journey, as we all know. So registration after 1 month, 1 year, bracing, 2 years bracing, and completion of 4th years. We have been very fortunate to get about 9 publications out of this in the last 10 years. This was a recent article published in the Global Research. Then we have this flat top talus, and then significance of Prani scoring, comparison between orthopedic surgeon and allied health worker in Pirani scoring, perception about braces, cost effectiveness, understanding the knowledge and perception about clubfoot, because this was when we started the programmatic approach. And the recent 2 articles in the last 2 months, the randomized parallel group non-inferiority trial complex comparing the efficacy of a 22-gauge needle versus a 15-blade to perform Achilles tendon tenotomy. And this is also published as a video in the Tropical Journal, Tropical Doctor rather. Important thing, and that is what I want to emphasize here, is the capacity building. Before I actually talk anything more about it, I really want to acknowledge the huge contribution of Professor Anis Bhatti, with whom we have been working very, very closely for the last so many years. Mehtab Pirwani as well. Anis Bhatti and Mehtab actually went to Iowa, University of Iowa. My colleague Mansoor Ali Khan, who is now the professor of orthopedics at Aga Khan, he was the first one to go to Iowa, and then Anis Bhatti Saab and Mehtab went, and then many other people actually went. And now if somebody writes to them that they want to come, they say, go to Dr. Bhatti, go to the Indus Clinic in Karachi. And if you want to go to Lahore, there are so many other people in Lahore and across the country. So with this capacity building was done in 2012 and 13. We got a funding from the University of Iowa and USAID in collaboration with the Pakistan Orthopedic Association Pediatric Forum at that stage, and now the Pediatric Orthopedic Society of Pakistan. We got grant to bring surgeons to Karachi. They stayed in Karachi for 2 weeks, came to our clinic, went to Bhatti Saab's clinic, went to Jamshoro, and they were trained in the Ponsati method. So we've trained 53 orthopedic surgeons in the first year, and then in the next year, because we had funds we had saved funds, so we trained another 40 in the next year as well. So this is what we've trained. At that stage, more than 90 centers were enrolled with the University of Iowa registry, and people have been putting in their data there. So this was the geographic location of the first 53 trained orthopedic surgeons. And Jose and Shafiq Pirani actually came to Pakistan in 2012 and 13, and we went across the whole country from Karachi to Hyderabad to Lahore. This is Professor Javed Iqbal there. That is the Vice Chancellor of the university. He was also actually the health secretary at that time as well. And then this is Lahore and Hyderabad again. So we went across the length and breadth of the country, doing workshops with them, giving hands-on training, and making sure that the Ponsati method is accepted and people do it the right and correct way. So this was another meeting here at Karachi, actually in this very hotel, in the hotel across. So that's Mansoor there, Bhatti Saab, Mehtab, myself, and Asif Qureshi. This is the Vice Chancellor of the KE University, Lahore, and at my hospital here, and then again this was, I think, in Lahore. 2014, that's right. So a few of the success stories, and I am not going to dwell about it, but what we have been doing is at every 4th year, so this was the first celebration of the completion of 4th years of treatment, which means now at that stage the children were off their braces. And we celebrate it every year. So just a few glimpses from there. And these were the children a couple of years back, the whole group that was there. And we call it Clubfoot Se Jeet Ka Jashan. So it's a celebration of the winning against Clubfoot. Recently, there was a National Clubfoot Coordination Workshop in Islamabad in June of this year. There were 19 participants from across the country. This was organized by ICRC and Miracle Feet together, and to have a discussion about the existing services and how to scale them up, and what are the challenges that are being faced. So these were the doctors who were there. Salik is sitting here as well. So these are his figures from his hospital, and then Gulzaman, Imran Marwat, these are all these centers are all financed or sponsored by the ICRC or Miracle Feet. This is Charles Foundation, this is an independent NGO, and this was my hospital data at that time. For the purpose of this presentation, I called all colleagues and asked them, though especially the ones who are not present there. So these are Professor Bhatti's numbers. These are the recent numbers since he has retired from JPMC. This second line, JPMC, Parvez has taken over since Bhatti have retired. So there are 1,500 cases there prior to retirement, and he's got another 1,200 in his various private setups that he's working after retirement. And then you can see these are Gurki Trust, big center at Lahore, and this is another big center at Faisalabad, 5,300, and Dow University is there, 5,000, and Civil Hospital, 2,000, Karachi, which is 2,000. I got this figure from Lahore, but I am not sure about that because this is a huge number. This probably is not right, but I'm not sure. But this is what I was given. So Jamshoro again, nearly 1,800 cases. Zamir Sumro, Chandka, doing a very good job, more than 2,000 cases. And then Bashir at Abbasi Shahid, and again a tertiary care hospital in one of the towns of Karachi. And this is a private lady who actually coordinates them. So I don't think, again, she's treating them herself. But she is very active in providing braces to these children. So I'm going to talk about that in a minute. So, as I said, these were the patients that we treated, IHHN, JPMC, LUMS, and PIA, 39 and 50 in the first 2 years. This is their trainees that they have trained, and their trainees are both orthopedic surgeons, and actually because it's ICRC and Miracle Feet, so they are actually focusing more on the physiotherapists rather than the orthopedic surgeons. Okay, and similarly in other cases. So these are the ones that we have trained recently in our own capacities, and these are basically our own postgraduate students, residents who have been trained in these 4 centers. Another very important thing is these workshops. We have been conducting Ponseti workshops since 2006, and that's why I said all hats off to Professor Bhatti and Javed Saab that we have been conducting these workshops across the country. Up till now, 56 workshops have been conducted by this group. The latest addition that has been is the establishment of a Pakistan Brace Bank. The braces have been a challenge for all of us. People have been providing various types of braces. This brace bank has been supported by the University of Iowa and some donors locally as well. The aim is to provide the Iowa braces, which the University of Iowa, Ponseti Group, the Ponseti International gets manufactured in China. So these are the braces currently that we are getting. We have recently this has come up. This is about last 6 months that we've given more than 300 braces throughout the country. जो थे सर वही बताएंगे. Maybe the figures may be wrong. I'm sorry for that. If that's वो ये सादिया ने बनाई थी तो शायद हो सकता है कि उसके नंबर में जी no this is the recent No, that was the previous container that we received in 2016-17. This is the recent brace bank that is established just last or 6 months back. Okay, so it would be amiss if I do not mention our clubfoot partners across the country. So ICRC has been very active, looking at humanitarian protection and assistance. Chal Foundation, their mission is to provide coordinated care, excellence, and sustainability of appropriate rehabilitation services, and they have been very actively doing that. Global Clubfoot Initiative, GCI, and Miracle Feet has just come in the country last year, and again they are working very, very hard to be able to providing all of these services that we've just talked about. So these are a few pictorial glimpses from this June meeting in Islamabad. Anis bhai has, sorry sir, I have just modified that because we passed that. So no untreated clubfoot in Pakistan by 2025 is what we are trying to achieve. We have been able to do away with a lot of the neglected ones, and most of the places now, and these centers, the ones that I talked about, IRC related centers, and GCI supported and Miracle Field supported, especially in KPK and some upper part of Punjab. We are very, very confident that inshallah in the next few years there will be no child born with clubfoot who is not getting identified and treated. Thank you very much.
I congratulate you, and you people have done a lot of work. Little correction, you have extended 5 years in your last, it was 2020.
So that is what I said.
Wait a minute. Then University of Iowa published a report in 2016, and it was written there, we have targeted these all things for this so much years, but they have completed everything 1 year before and all targets achieved. That report is published by the University of Iowa.
Sir, I agree with you. Reason I put that here. Okay.
Amen.
What we had promised them when we did those workshops with them and the training was that we will have 90 centers. Currently, we have more than 138 centers that are working. So, if you look at the targets, yes, we have, alhamdulillah, achieved all of those. But I think still a lot of work needs to be done at the ground level where.
One more compliment should be given. The mentees of that days is today the mentors of today's mentees. So we are not going to so far Tamargada and the Turban. They are with from Peshawar. Excellent work they are doing in Punjab. So we have become a little bit older, so we want to, and Javed's contribution, Salih's contribution is really big.
No, thank you. No, but we can't match yours and Amin Chennai and Mansoor's contribution over here. While we are talking about the services, I would like just to share my experience. Still, I mean, there is no doubt we have to learn Ponseti, and that is a wonderful technique. But still, we are struggling with orthosis at the family level. and our manufacturer level and as a profession. So still I find the most difficult bit is this orthosis. First thing is whatever we do, I'm talking about the local manufacturer, the quality is not good. I'm talking about my experience. So we approach some local, but still we are not satisfied. Then what happened as you did, my experience, some of the parents, one I remember is from Islamabad, he came, his child as a clubfoot, then he has a connection with the NGOs, and he is dispersing the good abduction orthosis from US, different NGOs. They send to them, and they just distribute just free of cost. That's what's happening at my end. Now we have 2 guys who are helping. But one patient, he brought an abduction orthosis. कहता है ये जी हम इंडस हॉस्पिटल से बड़ी मुश्किल से लेकर आए, तो वो जो आप यूज़ कर रहे थे तो आई वॉज वेरी हैप्पी और रियली आई वॉज सेटिस्फाइड. मैं सोच रहा था एक तो आई एम नॉट क्लियर जो आपके इंडस हॉस्पिटल से वो लाया था वो था अच्छा एंड आई वॉज वेरी हैप्पी. मैंने कहा ये यूज़ कर किसी और को दे देना. ये आप किसी वहीं से आते हैं या आप खुद मैन्युफैक्चर करते हैं?
नहीं, these are the Iowa braces manufactured in China, and we get a donor. तो जब पैसे जमा हो जाते हैं तो वो एक कंटेनर जितने पैसे जमा हो जाते हैं तो वो एक कंटेनर हमें भेज देते हैं.
अच्छा,
फिर हम डिस्ट्रीब्यूट करते हैं फ्री ऑफ कॉस्ट.
मैंने जिस 2 बंदों की बात की, एक उनमें से मेरा जो पेशेंट है, बल्कि इस लिहाज से मेरे साथ ही उसका इंट्रोडक्शन हुआ था, वो सियालकोट की मैन्युफैक्चरिंग जो ग्रुप है, जो वहाँ की इंडस्ट्री है बहुत बड़ी, हमारी चीज़ें दी हैं, उनसे भी अप्रोच कर रहे हैं. कुछ चाइना से वो लेके आया, मुझे बताते
Sir, we have approached local manufacturers
ये मैं कह रहा हूँ
in
कि
Sialkot and in Karachi. They have promised us, but actually they have not delivered us a good quality prosthesis yet. So till the time we get good quality prosthesis locally, we will. Because I have used locally made Steenbeck braces. There was a gap a few years back when we ran out of the Mitchell's braces, which we were providing initially, and which, as Mohammed Bhai is saying, they were provided to us by the Ponsati International. Then we did not have any of those. So we got locally made Steenbeck braces, and we gave them out for over a year, I think. They served the purpose, and if I actually showed a publication as well, perception of parents regarding the 2 braces. So we compared the Mitchell brace with the Steenbeck brace as well in that paper. So they serve the purpose, they are comfortable, there are no ulcers, nothing of that sort, but obviously they are locally made. So the perception was that they look better, they feel comfortable. The child is not going to tell you it's a 6-month, 1-year-old child, but he's not crying, he or she is not crying, there are no ulcers, there are no pressure sores, the skin is okay. It gives the local ones are fixed at 70-degree abduction bilaterally. Whether it's whichever side is, because that's the Steenbeck brace, which we actually got from the Red Book and then search the internet. All the templates and everything is there, you just need to download and they can make it easily. So we used that for I think a year and a half or maybe 2 years, and that was our, but yes, Anis Bhai is looking, I'm looking, we are talking to people all the time. If I went to Sialkot about 6 months back, even then I talked to somebody there and they said, okay, we will try. And somebody from Karachi said, I export the shoes that you bring from Italy. They are in Italy. So I said, please make these braces for us. But he made something which he wanted. You see, may have used the most expensive leather, but if they are not dorsiflexed, if they are not giving me that abduction, they are useless.
Yeah. So, but the last my comment, as a society, pediatric orthopedic society, I was just thinking to put in our next meeting that collectively we should make an effort. We should have some manufacturer over here, quality control, and then it should be sort of approved by society so that people can use that. Thank you.
Can I?
Sure, please.
Sorry. On 30 method, as you know, that was started in 2005 by Steve Mannion out here. Anyway, we have been doing these club feet surgeries and doing various camps in different places. and have now developed a very comprehensive setup of treating club feet. And until now, in the last 10 years, we have done more than 2,000 cases. And just to say that we have been manufacturing these orthotics, and these are custom made. So what we do, our team go to different places, say Dano Mathan, Dadu, Chiniot, Faisalabad, Swat, and the whole team goes there, and we do operations on around a couple of hundred, around 100 to 200 patients who come there for club feet. We get them corrected, and then our team from Chiniot, who manufactures custom-made orthotic supports, come there after 6 weeks of serial plastering, and then they make custom-made braces from the sheets which we import from China, and then they are changed after 3 months, 6 months, according to the condition and according to the shape of the foot, and then we keep on following them up for a year or two. But the only unfortunate thing is that I have never published anything, which I should, and then we should collaborate. We are already manufacturing it, and we have got the results.
It would be very nice to have those braces.
And then, we should collaborate, and we should, talk about it.
Yes.
As you can see, and I've got all the pictures and everything, whatever. We have done more than 2,000 up till now. Surgeries, yes. Yes, 2,000. They are right from 6 weeks to 52 years old. 6 weeks to 52, 56-year-old patients with neglected clubfoot. And I did one live...
Sorry to interrupt. We are getting shortage of time.
So, we should collaborate. That's what I...
Thank you. So we are moving to our first lecture. So for that, I would like to invite Dr. Muhammad Inan from Istanbul, Turkey. And the topic is cerebral palsy and the hip, knee, foot problems. Thank you.
They did double check, then I think it came. No. Hopefully I will finish today. Okay. Great. At least I see it. Okay then. Double. Thank you guys. This is not because of the technician, because this is a little bit busy slide. That's the 2 gigabytes. Because there is the videos. Hopefully, if we can play it, I will try to show you. My understanding, there is no time consumption because we can talk whatever we want. Then because Chairman, thank you very much. Then this is okay. This is I am starting with the hip problems, and I will go to foot. And I just say the quadriplegic patients has a higher risk. As you know, this is a very common findings. And this is the other things we have to know between 2 to 4 years and between 6 to 8 years, there is a peak risk for the hip dislocation. We have to control and screening these kids and at this age group. We know the pathology is coming from the iliopsoas and increased femoral anteversion and sometimes acetabular dysplasia. Clinical examination is very important. 2 signs is very, very important. One of them is hip abduction. Less than 45 degrees is the risk. And scissoring gait, the other risk. If there is these two problems, we have to screen these kids for the hip dislocation. And other things, we are not measuring the acetabular index in that group. We are looking at the Reimer index. Reimer index show us how the acetabulum cover the femoral head, and the 30% is, up to 30% is normal. For the normal kids, up to 20% is normal. There is a hip surveillance program, and we have the registry in our Turkey. The last year we tried to start it for the hip screening for the cerebral palsy kids. I will show my algorithm, not the general acceptance, just my algorithm is younger than 8 and older than 8. This is my algorithms this is the 8 years. Then if there is a less than 45 degrees of the abduction, we are going to pelvic x-rays. Reimer index is less than 30%. We are just control every 6 months. The Reimer index is between 30 to 60 degrees. We are going to soft tissue release. And we are control the x-rays. And if there is the Reimer index is still under the 30, just near annually control. And if Reimer index is more than 30, we are going to reconstruction. If the group is more than 60%, the dislocation, we know that from the literature, soft tissue release is not helpful. That's why we are going to, for the healthy children, we are going to reconstruction. If their situation or healthy situation is not good, we are going sometimes soft tissue just to prevent the hip in the joint. And for the soft tissue procedures, the common sense, please go and open release, do open release for the adductor release. But I personally do percutaneous release. Adductor longus and brevis release is quite enough for this patient's group. And I do 100% bilateral. If there's a revision cases, then I can do unilateral, but for the cases, I do symmetric abduction for every case. And this is before and after the adductor release. This is the osteotomy. This is my plan for the osteotomy. Just before in the operation table, I am taking the abduction, just abduction of the hip, and I am checking the position of the femoral head, and which is good. How many degrees abduction we have? For example, 30 degrees. We need that 30 degrees varus. And we check the internal rotation and internal rotation and abduction, and how many degree internal rotation is the best for this case, and we can understand the derotation, amount of the derotation for the intraoperatively. You can use any tool, the CT scan or the MRI or X-rays, but the intraoperative finding is very important, more important than these measurements methods. Just I want to inform you that if there is patients in the ambulatoire, GMFCS 1, 2, 3, don't go more than 120. But if there is a non-ambulatory case, go up to 90 because it is very safe for the redislocation. That's very important for me. When acetabulopelasty, literature is saying that if there is a dysplasia, if you don't do any iliac osteotomy, you have a higher risk for the redislocation. That's why you have to go, if you measure the acetabular dysplasia, you have to correct it. That's why if they need, I do bilateral DEGA plus varus derotation for these kids in the one stage. Bilateral osteotomy, according to my study in the DuPont, it is safe as the unilateral, because 2 times taking these kids to the surgical room is not good if you compare with the bilateral surgeries. If there's a scoliosis and hip dislocation, look at the pain. If there's a pain on the hip, go to hip first. If there's a pain on the spinal side, go to first the spine. Then other things is important things, inclination of the pelvis. If the pelvic inclination, because of the scoliosis, more than 20 degrees, you have to go first to scoliosis. then you are coming to hip. If there is a less than 20 degrees of the inclination, according to the patient's status, go first the hip or scoliosis. But main acceptance, you have to take the balance of the pelvis first to keep the hip joint intact. Older than 8, again we are going to Reimer index. If it's normal, every 2 years you can follow that. And more than 30, you are checking the degeneration. If there is degeneration, you are going to salvage procedures. If there is no degenerative arthritis, please do reconstruction for the hip. Complication is the heterotopic ossification. I classified like this. There is the simple for these kids. Implant failure, this is very common because of the osteoporotic bone. And redislocation is almost 10% if you look at the meta-analysis. In that group, 1 in 10 kids have a redislocation. The second subject is femoral anteversion. Today I showed some cases. This is the clinical examination, almost 90 degrees of the clinical internal rotation, Craig test. We check the tight foot angle to understand the tibial rotation, and you see the x-rays. This is my choices. If there is any hip problems, I am doing the proximal femoral osteotomy and derotation. If there is any knee flexion contracture or knee problems, I am going to distal. And I'm doing the extension and derotation osteotomy at the knee. I use the plate mainly, but I developed this derotational nail. That's for the pediatric population. Older than 7 years old, we use this intramedullary nail, proximal intramedullary nail. You can allow the patient second day, postoperative second day, they can walk. That's why this is the advantage for these kids, no casting, nothing. Of course, for the plate, I also allow for the walking after the 3 weeks, then no casting. This is I have 15 minutes, that's why I go fast. I try to give the main topics. That's the foot deformities. Hemiplegic patients has pes echinovarus. Diplegic cases has pes planovalgus. This is the common. And quadriplegic patients has a complex deformities. Physical examination is very important. We have to look at the pronation, supination of the forefoot and the cavus foot or planus foot, and we have to look at the calcaneus in the valgus or varus. Echinus gait is the very typical gait. There is the subgroups, but I don't want to give the details. We have to understand the dynamic or static. If there is a dynamic problems, and that means silver skull test, with the knee flexion, if your ankle joint, the range of motion is changing, this is the positive. That means this shortening of the muscles is coming to gastrocnemius. Soleus is not joining to this problem. Silver skull test is negative. That means there is a soleus and gastrocnemius complex shortening. Then that's our algorithm. Between 2 to 5 years, the dynamic deformity botulinum toxin injection. 5 to 8, soft tissue. Older than 8, soft tissue, and the bony procedures. This is the botulinum toxin injection. We have the kids. That's just the botulinum toxin injection is very effective for the dynamic problems, and there is no evidence to prevent the hip subluxation because this is just the prospective studies doesn't show any effect for the risk, but we use it mainly. For the gastrocnemius, I like to the Strayer, but you can use the Vulpius, Bowman, any kind of the release. There is no superiority of the techniques between the techniques, and that's why it is very simple for me. I use the Strayer, but you can use any technique. It is effective if you do that. For the achilloplasty, I use the percutaneous 3 incision techniques on the left side, and I like to do because our study, I do ultrasound study after the open the Achilles tendon lengthening and percutaneously. The ultrasound is very clear. There is no fibrous tissue if you keep intact the tube of the Achilles tendon. The risk is pes calcaneus. We have 400 cases they evaluated. Then we are sending for the publication. We compare the gastroc release and Achilles tendon release. Then there is no clear the risk for the Achilles tendon lengthening. Just we have to be careful about the knee flexion contractures and the obesity. If there is obesity and knee flexion contracture, both is the risk for the pes calcaneus. This is my post-operative protocol. I allow for the wall. I do short leg cast first. I am allowing for the walking for 20 days. Then after the 20 days, I remove it. I am giving the AFO. They can walk. Then up to 3 months, they have to use it. After 3 months, I just suggest for the night, but daytime, I am leaving the physical therapist. If they want, they can use it. But first 3 months, this is the obligation for me. The subject is, after the Achilles problems, dynamic pes echinovirus. This is the case of hemiplegic kids. We have to do Coleman block test. This is very classic. But for the CP kids, it doesn't work very well because they are not very adapted to this problem. On the left corner, you see the squeezing test. Just take the forefoot pronation and supination. You can see the calcaneus problem is dynamic or static. That's it. That's the same things for the Coleman and very simple. And this is you have to know for the tendon transfer, which muscle is active, tibialis anterior or posterior. Confusion test is very important. When you say to patients, please flex your knee, and you have to push from knee, and if foot is going to inversion and dorsiflexion, that means tibialis anterior. If it goes to plantar flexion and the inversion, that means this tibialis posterior. My choices for the tendon transfer is I use the FHL and tibialis anterior. I don't go too much tibialis posterior. We can discuss later on. This is not wrong, but this is not my way. Then just I want to show very shortly. This is my transfer tibialis anterior to the peroneus tertius. And I am preparing the tibialis anterior, just 2 centimeter incision at the insertion point. I am taking half of the medial part of the tendons. We can discuss also why we don't take the lateral. Then this is the tendons and separating them. Then we will discuss why use the lateral or medial. Then we are cutting it and suturing it in that incision. A little bit, yes, that's the suture, and that's the other tricky point. This is second incision at the proximal side. This is tibialis anterior. We are finding the tibialis anterior from the same root with the tibialis anterior. We are going to distal incision. This is very important. You are coming directly into this sheet of the tendons. You are taking it, and when you pull it, it comes separate from each other. Then if you use the knife, it's not good, and this you can cut the things. This is the peroneus tertius, just next to the fifth fingers extensors. We have to try it. We have to check because it shouldn't be the attachment to the fifth toe, and this is transferred to the lateral. It is very effective because you carry your tendon to the fifth metatarsus. That's why long way that's the very good lever arm for the foot. If you carry the tendon to the lateral cuneiform, is short. That's why this is very effective. Then you can suture it. I am passing that. And this is the results before and after. And this is the more severe deformity for the tibialis anterior. This is the results. That's a little bit the severe cases. There's foot problems, knee flexions, and after the extension osteotomy and tendon transfers, the stability is much, much better. This is the last subject is pes planus. These, the pes planus in the CP. I don't want to go too much detail for the X-rays, but this is the common findings for the problems. We do lateral column lengthening. Why we do lateral column lengthening? If you cut the calcaneus and if you do length the calcaneus, you see the cavus foot. How can it comes to medial? And you can create the arches of the foot. And this is the lateral column lengthening because we used a little bit different way. This is the just incision on the lateral, just anterior to the peroneal tendons. You are going to just directly to the subtalar joint. And this is the soft tissues, and you can clean it to see the joint surface. And you put the Homan there. This is the lateral corner of the calcaneus. Then just you are cutting this lateral corner of the calcaneus, and you are placing the other Homan is there. And this is the approach, and this is the osteotomy. You have to go check the neck of the calcaneus. You have to be careful not damage the posterior facet and anterior and middle facet. You are going directly to, you have to perpendicular to the femoral acetabular neck, and we are cutting the lateral side, but we are never cut the medial with the saw. That's why we use this one is to cutting the medial and the posterior side of the calcaneus. This is the lateral column lengthening. We are using the lamina separator. Then when you distract it, we have to control the calcaneocuboid joint and talonavicular joint should be at the same level. This is my product, I developed it. This is the expandable cage, like a cervical cage. Then you are placing between the osteotomy in the osteotomy side. Then you can check if there shouldn't be in the joint, and you are checking the position. If you need more extension, you will see them with a screwdriver. If you turn it like this, you can get more lengthening, and you can arrange it. The lengthening, the size of the lengthening for these foot problems. And you see here that this is the subtalar joint is intact, and this is the X-rays, and you see the cavus. Then you can close the classical way. This is the case examples. This is the follow-up. This is the algorithm for these kids. This is just, I want to show the complex deformity, because complex means you have two surgeries: posterior calcaneal osteotomy, medial column shortening or lengthening, lateral column shortening or lengthening. This is the kid's pes peroneal valgus with the severe deformity and hallux valgus deformity. We do lateral column lengthening, talonavicular arthrodesis, and hallux valgus surgery. You can compare the foot shape between the two videos. This is sometimes this is the a la carte surgery. You have to decide intraoperatively. And this is the severe deformity with the pes peroneal valgus. Our plan is, I want to go to, we need a soft tissue shortening sometimes for the peroneal tendon lengthening plus the tibialis posterior augmentation is. In that case, we started with the lateral column lengthening. After the lateral column lengthening, look at these pictures. The calcaneus is still in the valgus. And we go to the calcaneal osteotomy, and now after the calcaneal osteotomy, you see the forefoot is in the inversion, in the supination. You need take the first raise down. This is the cuneiform osteotomy, and after finishing your operation, that's the X-rays and the foot shape. This is before and after. That's the message. That's the common problems for the hemiplegic kids. Tendon transfer is very effective. Diplegic kids, lateral column lengthening plus medial column osteotomies can be used. And for the complex deformities, this is a la carte surgery. You have to concentrate every deformities, and you have to solve it. This is my last talk. Thank you very much for everybody. You are very patient. Thank you for your hospitality. Thank you very much.
Okay, thank you for the lecture. Any question regarding?
Thank you, very good talk. Just I want to ask if you are planning for the varus osteotomy of proximal femur. In this I am talking about the dislocation cases. So you will also go for the adductor lengthening, or you will not touch the adductors?
I don't understand the question. Say
The
again.
question
sorry.
is that if a child more than 8 years old
Uh-huh.
and you are planning for the varus osteotomy of the femur,
Yes.
so you will also do soft tissue procedure like adductor lengthening or not? Or you will
No.
just go for the osteotomy?
Just I'm going to for osteotomy. I don't use. You say the salvage. Is that true? I don't.
Yes,
I,
yes.
Personally, I don't like to use the salvage procedures. If it's possible, there is not too much damage on the femoral varus, the femoral head. I usually use the reconstruction. I am never go to the salvage. If this is the question, I am sorry. If
No. Actually, you said no, for the reconstruction of the hip, you said you will go for the varus osteotomy.
yes.
So simultaneously, you will do soft tissue procedure as well or not? Or you will just do
No,
only?
okay, sorry for that. This is if I do varus osteotomy, the adductor release is indirectly, you are indirectly release the adductor muscles. That's why for the CP case, adductor muscle is very, very, very important for the trunk stability. That's why I keep it. Just problem is, intraoperatively, yes, we had the surgery, I released the iliopsoas because it's blocked the femoral head for the reduction. That's why I release it. But for the adductor muscles, sometimes yes, it's very tight, but usually with taking the varus you can solve the problem.
The second question is that how much adductor you release? If you are, I am asking about for the surgery on the hip on disc, and you are planning for the adductor release. How much adductor you release? You just release the longer, or you will also add other?
I am going to adductor brevis and longus. If I need more, I am going to gracilis, not more. That's for me the abduction limit is the 70 degrees, not more. If intraoperatively 70 degrees okay. If you go more, you create big instability.
So you will release iliopsoas from the same incision. I use.
Thank you. That's
Question. When you are going for varus osteotomy along with the derotation osteotomy, how you calculate in the case of CP, because mainly this is posterior dislocations and you have to address for this. How you calculate? Pre-operatively calculate with CT, or you use some different method?
for the rotational.
Derotation osteotomy or at femur.
Yeah, I think that's the question is, if you do the rotation, how, because there's a posterior defect, and how do we know if you do too much of the rotation, it goes to posterior dislocated. That's the topics. The first discussion point is, the paper is not saying that in the CP case, almost just 30% of these patients has a posterior deficiency, according to the 3D studies. But because of the flexion and the rotational contractures, it goes to posterior. Then for the intraoperatively, I checked all the time. Whatever I measure, I plan it. After the osteotomy, I check the position of the femoral head in the joint. Which position is the perfect, I keep it in the proximal side. When I put the patella is forward, that means that's the ideal reduction for the proximal femur. That's my tricky point during the surgery, because if you look at the x-rays, any kind of the perfect x-ray has some error because of the anteversion things. That's why I checked after the proximal osteotomy, we can understand perfectly what is the best position, because our plan is the patella is looking forward, hip should be in the joint. That's why intraoperatively I got it.
My point was only that we are doing the pelvic osteotomy, we are doing the femoral osteotomy, we are doing the soft tissue releases. So it's a little bit tricky how much extent we have to do the osteotomy. So I asked it.
Thank you.
Such a nice presentations. I'm Dr. Salik. Your first talk on patellar dislocations. I'm quite interested in those because I'm doing quite a lot of congenital knee dislocations plus these patellar problems. I was noting your technique. It was very good. I really enjoyed it, learned quite a lot of things. But you are doing everything from the lateral side. I mean, you can do it, release the tight structures on the lateral side. We can do an osteotomy on the lateral side. But recently we are taking graft from the semitendinosus muscles.
You are taking graft?
From semitendinosus.
Mm-hmm.
And you did the graft from tensor fasciolata, split into two, and the anterior one was grafted to the medial side.
Mm-hmm.
So medial structures are relaxed, right? So that's why we do take a medial graft and then we reconstruct the medial structure from that. So is it the lateral structure, like the tensor fasciolata, is it enough to strengthen the medial structures if you transport it from the patella to the medial side?
Yeah,
Yeah.
you are totally right, because in that cases, that's our observation. Medial structure is loose. That's why we do plication for the medial side. They just not only transfer to the tendon, to the medial, to the patella, we do plication also. We are adding this is routine, because the very loose, because the patella is, for the cases, these cases, especially Down syndrome cases, the patella is on the lateral for a long time. That's why all medial structure is very loose and very length and too much. Then when you take the place, in the original place of the patella, medial, the capsule and all structure is very loose. That's why we suture it and we do plication.
But the valgus stress test was very positive in your case as well.
Mm-hmm.
So the medial structures were very, very lax. So does the plication alone address that problem, or you need to reconstruct?
That's also the good question, is
Yeah.
very good. But when you reduce the patella, you can see intraoperatively, that's okay. Because there is the instability on the medial, because the patella is not in the place, subluxated, then knee is going to too much the lateral, and like a medial there is no medial collateral ligament. But when we do reduction, we see that there is no problem on the medial collaterals. That's only the limited observation for the patient's group.
Okay, thank you very much.
Thank you.
I have two quick questions. Regarding the dynamic equinovarus deformity in the CP, we usually do the split transfer of tibialis posterior. There's a debate whether to do the TA or the tibialis posterior. Any experience with dynamic AMG, because it's the mid-stance firing, out of sync firing of either of these tendons that actually causes the deformity. So you transferred tibialis anterior. Any problem with any recurrences because of out of sync firing of TP? And secondly, in the planovalgus fit, is it just the lateral column lengthening you do, or sometimes you reconstruct the spring ligament, or you ever had to do a calcaneal slide, medial slide?
Yeah, that's just the 15 minutes talk, then 7 minutes the hip and 7 minutes the foot. That's why I am not going to too detail, but that's your question. But my point I will try to say, if first ray is in the down, there is a first ray is not going up. If you take the tibialis anterior, this is the drop a little bit more, which is not good. You have to use the tibialis posterior or FHL. The FHL transfer is not the usual, and there is no technique in the books. We use the FHL, it's very effective. Because I don't like the tibialis posterior. Why? Because you have to divide the two parts. This is originally, tibialis anterior is two part, no problem. But tibialis posterior, when you cut it, it is not a very smooth surface. When you transfer there, it is not sliding. It is, of course, you are taking the power from the medial, half of the power. You are giving the lateral. At least you lose the half the power of the medial side. That's why it's effective. I don't want to say that this is not effective. This is very effective to peroneus brevis transfer. But just my thinking, I have to take something from the medial or anterior. Then this is the good test, confusion test. If first ray is going to down, flexor hallucis is very good option, because first ray is going up, and that's a very good solution instead of the tibialis posterior. But don't go too distal, because at the beginning of our learning curve, we try to take longer tendons, and the first finger goes to extension. Then just behind the medial malleolus, we are taking and we are suturing the remaining part of the hallux longus to the digitorums to prevent the true extension.
Okay, thank you, Dr. Muharram. It was a very nice discussion, and now we are moving to our next topic. There is mixed fracture in children. For this, I would like to invite Professor Irfan Mehboob. Thanks.
Thank you, sir. So I will be talking about the missed fractures in children. I chose this topic because I am doing practice in a center where I get a lot of pediatric population with trauma. And most of the times, the junior doctors, they see the fracture, they see the X's over there, and they miss the fractures. So I thought that I'll just elaborate on this. The missed fractures are very common in children, and that is because the pediatric bones, they differ from the adult bone, not only as regards their composition, but also the response to the injury is very different. These fractures are subtle, their radiographic unfamiliarity, and there is always a challenging in order to distinguish the different injuries. And why the fractures are missed? It is because most of the times there is overwork in the emergency department. The fractures are difficult to detect. They appear with different signs and symptoms. The presentation on the site is different. There is always or maybe sometimes delayed presentation. The quality of the X-ray is very poor in ER department, and limited views are available. The outline of the bone, that may be very poor, and there may be a lack of knowledge at the junior radiologist. The physial injuries are there, and the physial lines, they add to the complexity. Most of the fractures are incomplete, and these are seen by the junior doctors. So all these factors added together lead to most of the times fractures which are missed. Now, if the fractures are missed and they are not treated, they can lead to long-term disability, and later on there could be cosmetic issues. And the missed fractures are the commonest cause of medico-legal issues, may not be in our country, but in most of the countries. And it is the largest source of malpractice claims in the ER department. Understanding the mechanism and the radiographic appearance of the pediatric skeleton trauma facilitates the detection of the injuries. We should understand that children are not small adults. And whenever the force is applied to the bones, it propagates through the bone because of the rigidity and results into fracture. But in children, the fractures are not complete, they are incomplete, because there's a lot of collagen in the bones. There's increased cartilage at the various parts of the bones. The bones are less rigid. There's increased elasticity of the bones, the increased porosity of the immature bones, and the higher likelihood of fracture because of this problem, but there's less progression of the fractures. And one should understand that the outer periosteal sleeve of a child bone are proportionately tougher than the inner fibrous cortex. And the pediatric fractures, they represent cortical deformity rather than the discontinuity. And the physis, which adds to an element of complexity to the pediatric skeleton. The bones are highly vascular, and they provide the physial plates, they are highly vascular, and they provide both the longitudinal and the transverse growth. So the radiological appearance is as a straight and lucent band. Now I'll discuss few other problems, that there are thick bands which are extending from the epiphysis to the metaphysis, and they prevent in displacement of the bones at this level. Now if we see the incidence of the missed fractures all over the world, there are certain studies which are done. In certain retrospective studies, the incidence is 2 to 9%. In certain prospective studies, the incidence is as high as 11 to 27%. So I will discuss few commonly missed fractures in children. This is the torus fracture, which is very common, and it is very commonly mixed. The mode of injury is the axial load, and you can see the arrow will point out the site of fracture. Anyone who is not well aware of these X-rays, they are going to commonly miss it. Then there is a buccal fracture. This is almost the same as the torus fracture. This also appears in the distal radius and ulna, and very commonly missed. These are the plastic fractures. Now in this case, there is only increased deformity or angulation of the bone with no clear fracture line. But if you have an X-ray of the opposite limb, then you will see that the convexity of the bone is increased as compared to the as compared to the normal. So you can suspect a fracture over here. Green stick fractures. These are the incomplete fractures, and they involve only one cortex of the bone. And if you don't see this arrow, then most of the junior doctors, they are going to miss it, and they do miss it. Now the physeal fractures, the type 1, 2, and 3. Most of the time, in normal cases, we see that the physeal plate that is smooth, and the distance or the lucency that is equal on both the sides. But if you see over here, there's increased lucency, and that demonstrates a fracture. Now you see on this side, there's increased lucency, and there's a line extending into the metaphysis. This is type 2 physeal injury, which is not only a shearing, but it is also a shearing and divergent force. Now over here again a physeal injury, but there is only increased lucency in the growth plate or the physeal plate, and this is also called the little ligger's shoulder. It's very common in the children between the age of 11 and 16 years, and most of the time it appears in the children who are playing cricket or the pitch ball. Now the fracture at the base of the coracoid, that is again increased lucency over here, and this is as a result of direct trauma, very commonly missed. The sternoclavicular dislocation is also a type of fracture which is usually missed. There's a supracondylar fracture which is very common, and the mode of injury is a fall on the outstretched hand. But if the fracture is of this type, where there is hardly any clear line, then it's very likely that you can miss it. So if you have a lateral view of the same patient, you will see that there is collection of the fluid, both anterior and posterior, and the anterior humeral line, which passes from the posterior 1/3 of the capitulum, is passing much anteriorly, and that gives a high index of suspicion that there's something is wrong, and of course a fracture. Now the radial neck fracture is not that uncommon in children. Again, the mechanism of injury is fall on the outstretched hand, and you can see over here the slight displacement and a periosteal reaction. Maybe the patient reported after a few days. Olecranon fracture. This is a line which appears, and again, I think if a doctor is not well aware of the anatomy, they are going to miss it. Now the lateral condyle fracture. A simple lateral condyle fracture which is undisplaced is very difficult to make the diagnosis. It's only the irregularity of the cortex on the lateral side which will give you a suspicion of a fracture. Then the medial condyle avulsion. This is actually an avulsion of the medial epicondyle where there is attachment of the tendons, and it usually comes and lies in the joint. And the patient or the child that comes with a problem that he or she are unable to flex the elbow, and there is a history of trauma, that should give you a suspicious that there is a fracture of the medial epicondyle. Then there is displacement of the ulna and radius and of the. Now in children, the scaphoid fractures are rare, but one should not neglect it. So see over here, the continuity of the cortical surface of the scaphoid is disturbed, and there is a fracture over there. Now the slip capital femoral epiphysis. The only suspicion is the irregularity of the physeal plate, or if you see the frog leg lateral view, then you will see the slight posteromedial displacement. That will give you a suspicion of a fracture. Now tibial spine fracture, you can see the fracture line over here. Now this is a toddler fracture. They usually appear in the children between the ages of 8 and 10 years. When they start walking, the bones are very fragile and they jump around and they can have this fracture. Again, one which is difficult to make the diagnosis. The buckling fracture or the trampoline fracture in children. Now again, a buckling fracture on the lateral view. The cuboid fracture, the only suspicion is the sclerosis of the one cortex of the cuboid. Then there is a bunk bed fracture. The children who use the bunk beds, they fall while sleeping and they can have a trauma to the first metatarsal and they complain of pain and swelling over there, and if you have an X-ray, you will have this appearance. Now, from this we understand that pediatric musculoskeletal trauma is easily missed on X-rays. Pediatric bone is more porous and flexible. Developing physes and apophyses are more prone to the injury. Knowledge of unique fracture types and sites specifically is crucial. Early diagnosis can prevent significant cosmetic and functional impact. MRI images may be needed if no sedation is required. Thank you.
Thank you, Professor Irfan Mehboob. Any questions regarding his lecture? Okay, so we are moving to our final lecture, that is on the congenital fixed patellar dislocation in children. And for that, I would like to invite Dr. Saeed Ahmed Jadoon.
Bismillahirrahmanirrahim. I am Dr. Saeed Ahmed, and I am going to present a talk on congenital fixed patellar dislocation. Congenital fixed dislocation these are not the traumatic or sports injury related dislocation. These patellar dislocation are usually present from the birth, and they are permanent, and there is irreducible dislocation since birth. And the quadriceps, because these dislocations are present since birth, so the quadriceps also develop laterally on the femur. And there is a tight iliotibial tract leading to genovalgum and external tibial torsion. And they also can lead to a foot deformity like equinus deformity. And simple procedures like lateral release and medial plication, which was done in the past, most of the time they do not work in these cases. This is a case of 8-year-old girl with bilateral congenital fixed dislocation. Now both the patellas are lying laterally over there. And on the knee AP view, although this is a short film, but short X-ray, but there is no genovalgum deformity. So we did excision of in this because the iliotibial tract is tight. So we did excision of the iliotibial tract from the greater trochanter till 4 centimeter above the knee joint. Why 4 centimeter? Because iliotibial tract, it's a lateral stabilizer of the knee as well. So we have to preserve part of the iliotibial tract. And do a subperiosteal elevation of the quadriceps, which may be called as a quadricep repositioning or quadriceptoplasty. And then transfer the lateral half of the patellar tendon beneath the medial half of the patellar tendon near and attach it to the periosteum near to the MCL attachment. And then do a medial plication and vastus medialis obliquus advancement. This is a picture. You can see then a lateral space is created. In this picture, you can see the quadricep is lying laterally on the femur. Then we elevate the quadricep from the femur and reposition it anteriorly on the femur. And after transferring the lateral half of the patellar tendon to the MCL, so the patella is elevated and now it's in the trochlea, and you can see the position of the quadricep has changed from lateral to anterolateral. Now this lateral joints, we have to reconstruct this lateral joint space with the help of the iliotibial tract, which we have removed previously, so that the synovial fluid does not come out of in the wound. Otherwise synovial fluid leads to non-healing or could lead to infection in the wound. So it's important to create the lateral joint space. And it's important that we should achieve a 60 degree flexion on the table, and the patella should be stable on the table. Our cast would not give stability to the patella. So we have to stabilize the patella per op. So you can see now I have applied that iliotibial tract laterally. So the flap of iliotibial tract to create the lateral joint space. So somehow these X-rays are not shown. I don't know why it's not shown. But in this X-ray, the patella is well reduced, although it's not shown over here. Now this is the second case. We will see it in a second case. You can see this patient walk with the flex knee gait and equinus as well. This is because of the tight iliotibial tract. And you can see the patella is lying laterally over here, causing a genovalgum at the knee joint, although there is no true valgum at the bones. That is because of the tight iliotibial tract. At the joint line, the genovalgum has been created. And in the skyline view, you can see the patella is lying laterally, inferiorly, and it's not reducible. It's lying fixed laterally. So in this case, these are the video, or op video. So the patella is lying over here. So we excised the iliotibial tract. We did repositioning of the quadriceps, transfer the lateral half of the patellar tendon beneath the medial half to the MCL attachment, and then tight the lateral medial retinaculum and do a VMO advancement as well. So this was a pre-op X-ray, and this is a 6 months down the line X-ray. The patella is well placed in. And these are the videos of the same child. This patient is almost 3 years down the line, but when this video was created, that was 6 months. So the equinus has settled, the flexion deformity at the knee has been settled. Now another case, case number 3, fixed patellar dislocation. In this case, when we did a calculation, the the lateral condyle was hypoplastic and there was a genovalgum deformity as well. When there is an associated genovalgum deformity, then we have to address that genovalgum deformity as well. Otherwise, our patella would not reduce. So you can see the patella is lying lateral over here. And we did osteotomy, distal femur, corrective osteotomy, excision of the iliotibial tract, repositioning of the quadriceps, transferring the lateral half of the patellar tendon beneath the medial half to the MCL attachment. And you can see the valgum has created, the valgum has corrected. This patient is also more than 3 years down the line. Now, this is another case. In the past, she had received multiple treatment in the form of guided growth that failed, then Elizarov, and unfortunately, this was a case of bilateral congenital patellar dislocation, and she had suffered a lot. She has developed a severe flexion deformities at the knee, and she has almost lose the ambulation. She can hardly walk few steps with the help of the walker. So this patient we need to manage aggressively. So we excise the iliotibial tract, position the quadriceps, corrected the genovalgum. As this patient was mature enough, so in this we didn't transfer the lateral half of the patellar tendon. Instead, we did a Fulkerson osteotomy of the tibial tuberosity to bring the to make the patella align. And you can see that these are the screw of the Fulkerson osteotomy, and the patella position has been repositioned on the condyle. Sorry for the poor quality X-ray. And now you can see this patient is now almost 1.5 years down the line. She is walking without any support. Previously, she had left going to school because she was unable to walk for a long time, and now she is going to school and enjoying her life. So in summary, in fixed patellar dislocation, the quadriceps develop laterally, there is a tight iliotibial tract, and by doing a simple lateral release and medial plication, these forces will not allow the patella to be in reduced position. So we have to address the quadriceps, we have to address the iliotibial tract, and at the same time, if the patient is immature, then do distal realignment by Goldwith procedure, transferring the lateral half to the MCL, and if the patient is mature, we can do a Fulkerson osteotomy. And at the same time, we do not have to miss a genovalgum deformity. Thank you. Any question from the audience? Oh. Because the medial retinaculum is stretched out, sometimes you have to excise a part of the medial retinaculum. Then VMO advancement is also important, because you have to bring the vastus medialis at least sometimes into the middle or even below the middle level of the patella. And the most important is that we should not miss the valgus deformity at the distal femur. If there is a valgus deformity, then we have to address that. Any more questions? Thank you.
free papers की शुरू करें free papers.
Usama? Yeah, okay, for free paper presentation, I would like to invite Dr. Muhammad Usama.
I'm Dr. Muhammad Usama. I'm a resident at Gurki Trust Teaching Hospital. I'm here to present my findings on analysis of functional and cosmetic outcome of Green and Bank procedure in spastic cerebral palsy patients. So presenting the background. Okay, wrist deformities are common, especially in these patients, the spastic cerebral palsy patients. They present to us with wrist deformities including forearm pronation and have wrist flexion as well as ulnar deviation in the joint. And as is the obvious, it's a congenital disease. It's congenital or young people disease. Its presenting population is younger population. And among the surgical procedures that include non-bony procedure is the procedure of Green and Bank procedure. It is the procedure in which we try to deal with the deformity in terms of transfer of flexor carpi ulnaris that is in the flexor compartment of the forearm to the extensor carpi radialis longus or brevis. We make an incision over the flexor carpi ulnaris, turn it around the wrist joint and then place it through a small poke in the extensor carpi radialis brevis and stitch over there. And they then gave us flab, later on rehabilitation is done. So here we aim to assess the outcome of this procedure, both in terms of functional outcome as well as the cosmesis. So we would like to assess not only the objective but the subjective outcome of the procedure as well. As it's a disease, we would like to see how much ease can we bring into the life of the patient. We are going to use the modification of Green and Bank procedure. It is the Samuelson modification. So coming to the methodology, we assessed a total of 31 patients who underwent the aforementioned procedure. We did a retrospective study. Our mean follow-up was 36 months and the function improvement was assessed, as I mentioned before, Green and Bank rating scale as well as the cosmesis. This is X-ray of one of the patients and the deformity. So coming to the scale that we are going to use, it's a Samuelson and Prieto modification of Green and Bank's rating scale. In this scale, we categorize the patient's outcome in terms of 4 categories: poor, fair, good, and excellent. Poor is the one when the patient can use the hand only as a paperweight. He has got very poor absent grasp and release and so poor control. Fair is when the patient can use the hand as an aid with no effectual use in dressing. That is one of the lifestyle things that a patient has to do, and has got moderate grasp and release. Good is when he can use it in daily life activities of dressing and eating, has got an effectual grasp as well as release, and has got a good control over it. And excellent is when the hand use is good in terms of daily activities of dressing, eating, and general activities. So coming to the crux of the study, the results. So this slide tells us the general information. Sorry. Can I go back? Okay. General information regarding the gender. We had 13 females and 18 were males. This pie shows the results in males. It was 62% was satisfied with the results and 38 had neutral feedbacks. And the mean age of the patients was 12.6. So these are the pre-op scores. We had a total of 20 patients who had poor categorization on Green and Bank categorization scale, and 11 had fair. And these are the post-op results. The results are very obvious. Though we had some poor results, 5 of them had 11 of fair result as much as we had before, but we had 14 good functional results and 1 with an excellent result. So as per green and bank rating scale, preoperatively 20 with poor and 11 at fair, this improved to 5 poor, 11 fair, 14 good and excellent, on 1 excellent on the last follow-up. And these results were statistically significant with a p-value of less than 0.01. That signifies these were highly significant results. And the analysis test we used was ANOVA, analysis of variance, because it was categorized among more than 2 groups. Next is the objective assessment. As I mentioned before, if you are treating a patient and he himself isn't satisfied, so then you can't specify any rating scale that these rating scales tell that your patient's results are good. So if your patient has good subjective assessment, it's a good scale. We quantified them on the basis of cosmetic outcome that the patient himself said. Is he satisfied? Had his neutral feedbacks or not satisfied? 52% of the patients were satisfied with the intervention and had the satisfactory result as per their own observations. This is the same, quantifying that 51.16, that is more than half of the patients were satisfied. And there were the other figures. 32 had neutral and only 16% were not satisfied. So, coming to the conclusion, green and bank procedure has good outcomes, not only the objective but subjective as well. So, it was good at treating the deformity, the problem with which patient comes to you. And though we can do further assessment of other trend and transfer procedures, as multiple of these procedures are available for the wrist deformities, and comparative analysis would give us better result in terms of various meta-analysis or systematic reviews. Thank you so much. Are there any questions? First. This one? Which one? Okay, thank you so much. Any other person? Any questions? Thank you.
Okay, for next pre-paper presentation, I would like to invite Dr. Farman Haq. Here. Dr. Farman. Or Dr. Irfan. Dr. Irfan Ali Shia. Is he there? No one is here? So I would like to invite Professor Dr. Atiku Zama. Doctor? Okay, Dr. Faraz, come in.
Bismillahirrahmanirrahim. Respected seniors, colleagues, and my dear teachers, Assalamu alaikum. I'm Dr. Faraz Ahmed Khan, working as a PGR at Orthopedics and Spine Department, Gurki Trust Teaching Hospital, Lahore. I'm here to present my paper, which is about the functional outcome of the titanium elastic nail in a femoral diffusal fracture in children. This photo has captured the whole orthopedics and spine department at Gurki Trust Teaching Hospital, which is functioning under the esteemed guidance of His Excellency, Sir Professor Dr. Amir Aziz. Now, this femoral diaphyseal fracture is the most common fracture of the lower extremity, and incidence rate is 20 to 25 per 100,000 children per year. Now, this was Abdullah, a 6 years old child presented to us with pain in the right thigh secondary to road traffic accident within 5 hours of the trauma to the right thigh. On examination, skin and distant neurovascular status was intact. X-rays of the patient shows an oblique fracture of the diaphysis. After the assessment of the patient in pre-op preparation, we did titanium elastic nail, closed, not open. And this is the immediate post-op X-ray after the tense nail, and this one is at the 12th weeks, which shows a solid union. Now, objective of this study was to determine the functional outcome of the flexible intramedullary nail in the diaphyseal fracture in the children. Now, this was a prospective study design of 62 patients in which we did flexible intramedullary nail, and this study has been conducted between the February 2022 to 19 August 2022. And Flyn's criteria of titanium elastic nail was used to assess the functional outcome of the patient, which was at 3rd, 6th, 9th, and 12th weeks follow-up. All the data were entered and were analyzed while using SPSS 27 version. This is the Flyn's criteria. You can see this has 4 variables, which the first one is limb length inequality. If it is less than 1 centimeter, it is excellent. If it is less than 2 centimeter, it is satisfactory. If it is greater than 2 centimeter, then it's poor result. And about male alignment, up to 5 degree, it has excellent. And 5 to 10 degree, it is satisfactory. While greater than 10 degree, it is poor results. Now, if there is no pain, it falls in the excellent and satisfactory result. And if there is pain, then it shows a poor result. Now, complication, if no complication, then excellent. If minor, it is satisfactory. And major complication, it falls in poor results. You can see the demographic results in our study. More than half of the patients were male, which were 69%, and 31% of the patients were female. Now, the mean age of the patient were fall at 8.32 with standard deviation of 2.23. Minimum age was 5 and maximum was 12. And the duration of the fracture since the patient got trauma and presented to us was 4.27 with standard deviation of 3.8. The range was between 1 and 18 days. And the weight of the patient was, the mean was 23 and the range was 10 to 32 kg. So this is, you can see the this graphical representation of the result. So in 91.9% we got an excellent result, while in 8.1% satisfactory result. Unfortunately, there was no patient who was lying in the poor categories. Okay, now the functional outcome by gender. So 39% of the male shows an excellent result, while 18% female shows excellent result. And in satisfactory category, the male were 4, while the female was 1 patient. And functional outcome by the age group. So between 5 to 8 years, we got an excellent result in 32% or in 32 patients, while satisfactory in 4. In between 9 to 12 years, we got an excellent result in 25 and satisfactory in 1 patient. Okay, so it's about the, so this is the duration of disease has significant effect on the functional outcome. Is P was less than 0.5, while the age and gender, although there was an impact on the outcome, but that was not so much significant. This is a study, a recent study which has been published in 2017 by Temarkar et al. In this study, he shows that tense nail in 80% of the patient, as far as the functional outcome is considered, has shown 80% excellent result, while 20% has shown satisfactory result. Now, as far as the literature in or cases that we are doing at Gurki Trust Teaching Hospital, this has been concluded that children with femoral shape fractures treated with flexible intermediate layers achieve better and faster recovery with rare complications. Therefore, flexible intermediate layer is safer and effective mating for treating femur shape fracture. Thank you so much for the session. Any questions?
Okay, thank you, Dr.
Okay,
Frost.
sir. Exclusion criteria was there, sir, that patients that was between 15 to 32 kgs, and those patients between 5 to 10, that were the inclusion criteria. For what fracture, excuse me? Type of fractures were transverse and oblique, so both were in this. Excluded. That was the open fracture, sir, and very severely comminuted fracture. That was the exclusions. Okay. Thank you, sir. Thank you so much. What, sir? Excuse me? Yes, sir. Yes, sir.
Type of the nail.
Yes, sir. Thank you so much,
Other
sir.
name is that.
Thank you so much.
Okay, for the next free paper presentation, I would like to invite Dr. Jawad.
Coxa vera. Bismillahirrahmanirrahim. I am Dr. Jawad, Senior Registrar from Gurki Trust Teaching Hospital, working in pediatric orthopedic team of the Gurki. These are my mentors of pediatric orthopedic team. I am the part of this team. This is our Gurki family. So learning objectives of this presentation will be, by the end of the presentation, you will be able to understand developmental coxa vera, and also will be able to understand the goal of surgery and expected outcomes. So I will like to define the developmental coxa vera. It is a non-congenital, non-traumatic condition in which there is characteristic decrease in neck shaft angle of the proximal femur, and it is usually less than 120 degree. And it is also characterized by an ossific defect that is called Fairback's triangle. That is visible in this down diagram. Natural course of developmental coxa vera. As it is a developmental condition, so by the time the child is developing, there is increased shear forces on its head and neck, and there will be more bending and more varus deformation, and this will result into aggravation of the disease. So that's why it is called developmental. It is a progressive disease. So there are some significant radiological markers for this disease that are HE angle, Hill-Greenell epiphyseal angle. Normally it should be around 60 degree, but normally it should be around 20 degree, but in developmental coxa vera, epiphysis is more vertically oriented. Your physeal line is more vertically oriented. And then neck shaft angle, as we all know, it ranges from 120 to 135 degree, but in these patients, it is usually less than 120 degree. There is another angle that is called HS angle, head shaft angle. It is depicted in the B diagram. In usually developmental coxa vera patient, the neck is very small. It is difficult to take the exact angle from neck to determine the neck shaft angle. So another method is devised that we take a physeal line and draw perpendicular to that, and from that perpendicular line we take the axis from the long axis of the shaft. That is called HS angle or head shaft angle. So what we are going to do in these patients, we will going to do a valgus osteotomy, the goal of which will be correction of Hillgriner epiphyseal angle below 38 degree. As we have already discussed, it is usually more than 60 degree, but we will make it to less than 38 degree. And another benefit we will achieve, the shear forces at the neck and at the physeal scar and the physis will turn into compression forces. And the restoration of neck shaft angle will also occur. Study objective. The study we have conducted, it is aimed to investigate the short-term outcome of the both in radiological and clinical terms of the valgus osteotomy of developmental coxa vara. So this is our sample selection. Inclusion criteria included the developmental coxa vara, HE angle for at least 45 or more, head shaft angle 110 or less. Patients, there were few patients that had the typical ossific defect called Fairback triangle, and there were other patients that don't have the Fairback triangle. Both were included. And exclusion criteria include any history of trauma, any history of infection, the coxa vara that is secondary to healed scaphy, and other dysplasias. So this is our study outline. We conducted a study between February 2015 to July 2020, and that was retrospective study at the Gurki Trust Teaching Hospital, clinical examination, Harris Hip score, LLD, these are all clinical measurements. Radiographic measurements were HE angle, HS angle, and 19 patients were included that were fit our inclusion and exclusion criteria. So these were the procedures we done. Adductor tenotomy was done in almost all patients. Subtrochanteric lateral closing wedge osteotomy was done. There was no we didn't do trochanteric apophysis in any of these patients. And we fixed it with a 135 angle device, either mini DHS or blade plate. And we did regular follow-up of these patients. So valgus osteotomy, a little detail of that. Subtrochanteric lateral closing wedge osteotomy fixed with 135 degree angle device, and we protected this osteotomy with a spica cast. And this is the data. Mean age was around 10 years. There were more male patients as compared to female patients. These are demographic data of the patients. So these are our combined demographic data on the upper line and results on the below line. As I have already mentioned, the most of the demographic data. So I will focus on the results. From there was mean LLD of 4.2 centimeter, and it improved. LLD reduced to 1.7 centimeter. Neck shaft angle on the right side increased more, around 30 degree improvement, and on the left side it is around 16 degree improvement. And Hillgriner epiphyseal angle, right sided there was 18 degree change, and on the left side there was 10 degree change. And Harris Hip score, last of the slide from above the Gurki monogram, Harris Hip score improved from 55.26 to 82.05. That's our functional outcome. Other ones are radiological. Again, that data is represented in tabular form. So the conclusion, the subtrochanteric valgus osteotomy than we do in developmental coxa vara will achieve a better outcome both in radiological parameters and as well as functional parameters when we measure on Harris Hip score. Subtrochanteric valgus also improves. It is not a limb lengthening procedure, but it secondarily improves the limb length also. As we have seen from mean of 4.2 centimeter, it has reduced to 1.7 centimeter. And there was no recurrence of the deformity during short-term outcome. These are our few cases. As this patient also has the Fairback triangle present here. So we have fixed it with mini DHS plate. क्या excuse me, वीडियो प्ले कर दे, वीडियो प्ले. I think due to transfer, video is unable to be played. And this is another case in which there was suspected hip dysplasia as well. So Salter osteotomy was also done. This is it's almost 2 years follow-up. And this is another case of left-sided fixed with mini DHS plate. These are few cases of the whole study. Total 19 patients were operated. Thank you. Any question?
Yes.
इंट्राऑपरेटिव कह रहे हैं नहीं वो नहीं
It's free paper. It's free paper presentation, so I think it's not included in this. Okay. Okay. For the next final free paper presentation, I would like to invite Professor Dr. Atiq Uzama. Thank you.
Thank you very much for these 5 minutes in 2 pediatric sessions. I am going to present the intracapsular arthroplasty in the hip. This is also called a Clona procedure. These are my mentors, Professor Amir Aziz and Professor Chirag Saab, and this is our institute, the Gurki Trust Teaching Hospital. At the end of this presentation, we will be able to understand the pros, cons, advantages, disadvantages of the intracapsular arthroplasty. The options after the 8 years of age in DDH surgery, they are different. Like you can have a steel triple osteotomy, like in this patient we have done, and it has a very good outcome. Then you can do the Gans osteotomy, like done in this patient, bilaterally with a difference of 1.5 years in between the 2 procedures. And you can do the shelf procedure as a salvage procedure after the 8 years of DDH. But when a 22 years old male came to you with this deformity, you are limited, you have a very limited options. So we have done a procedure which is called the intracapsular arthroplasty in this patient, and you can see the results, how much space has been formed on that X-ray, and what is the range of motion of this patient, and he is pain-free. This intracapsular arthroplasty, it was defined by Clona in 1938. Then it becomes unfamous, and there was a sparse literature on it. We published in 2018 our 5 cases only that we have done, and the results were so excellent that all of the patients, they have a good McKay scoring system and the Severin scoring system that encouraged us to do the more cases. There was no AVN in any case, and all of the patients, they have done very well. They are pain-free, and they can have a good range of motion. So we now published our 30 cases in the JPOA journal. It is ready for publication. But this time, we have the AVN, which is around 11. These patients, most of these patients, they are pain-free. We have converted the 1 Clona procedure into the total hip replacement, and we have the complication of subluxations immediate post-operatively in 3 patients, but then we have to reduce it, put the intra-articular wire, and they also performed well. What is the Clona procedure? It is just like a total hip replacement, but you are not replacing anything. So you are going to open the acetabulum from the same approach as you are doing for the DDH. Gans has also explained this procedure, but he do the surgical dislocation. He goes from the lateral side, do the greater troch osteotomy, then go anteriorly, open the capsule, and then do this procedure. But we are doing it from like a Somer Valley approach from the anterior side and reach to the acetabulum, ream it like a we do in a total hip replacement. We ream till the cancellous bone has been reached and the good acetabulum has been formed. And then we wrap the capsule over the femoral head. A lot of capsule is present when the hip is dislocated. There is no problem in finding the capsule. The only problem is to detach it from the acetabulum, especially from the posterior side. So if you take the good exposure, if you leave that capsule there, just cut a little bit far away from the posterior border of the acetabulum, you will be safe. There will be no sciatic injury. We have one sciatic nerve injury in a clonal procedure. That is not a direct injury, that is because of the traction. So you can see the results. These are the follow-up x-rays, and in the last x-ray you can see the space that has been formed which was not present in the post-operative x-ray, and the range of motion of the patient. This is a 22-year-old female in which we have done the Chiari osteotomy on the left side. She was so satisfied with the procedure that she says that do my right side also if you have any option, because the doctors, they say there is the only option, that is a total hip replacement. So we have done the clona procedure in it, and this is the way we wrap the capsule over the femur. And this is the 1.5-year follow-up of this patient. She is walking without any support. Both the legs, they are equal, and she has no pain. She is a 14-year-old female in which the clona procedure has been done, and after 1 year follow-up, she had a limp. That limp is because of the coxa vara, and the greater troch, it is touching the ilium, and that causes the pain. So we have done the valgifying osteotomy in this patient, and this is the 1 year follow-up after the valgifying osteotomy when she came for the removal of the DHS. I think there is sitting and squatting at the end. Okay. So the take-home message is that preserve the hip, trying all means. Hip arthroplasty is the amputation of the hip and can be done anytime, even after this hip preservation surgery. And DDH after 8 years of age, there are different options, and the clona procedure or the capsular arthroplasty of the hip, it has a very good results. What are the indications of the clona procedure? These are the two. If there is no cartilage in the acetabulum, if you go in, because otherwise if there is a cartilage inside, then there is no need of doing the clona procedure. You can redirect the acetabulum by any way you like the triple osteotomy or the Gans osteotomy. So if there is no cartilage there, then there is no fun in reducing the hip. It will become painful. And number two, if there is, the acetabulum is in oval shape and it does not match with the head of the femur, so then you have to do the clona procedure, and it will help you in making the patient pain-free. Thank you very much. Any question?
Yes, any question regarding the procedure?
We have a strange finding while doing the clona procedure. And that is that there are the two capsules inside. When we remove that thick capsule, I don't know what that is, a capsule or that is some fibrous tissue. there is a very thin capsule which is lying over the head. And we do not open it, even just release it from the posterior capsule and put the head in the same way into the acetabulum. Clona procedure is a difficult procedure. It is not as simple as I have told you. Because it is an adult patient, it bleeds a lot. Dissection is a little bit difficult. And the things, because the anatomy is disturbed, it is a congenital disorder. So you will find the difficulty. It is not a simple way of doing the total replacement, because he has watched over the case, therefore he knows that some difficulties can occur. Any other question? Yeah. Excellent question. You do not do the capsulorrhaphy in total hip replacement also, but that is stable. Why? Because the soft tissues around it and the abductor muscles, they make it stable. So this is just like a total hip replacement. Only you are not removing the head and not replacing it with a metal. Number one. And number two, you are doing the central dislocation of the hip. So you are reaming the acetabulum, so you are doing the central dislocation, and that also makes it stable. Still, you are right. Sometimes it is unstable. Like if you do not find a good capsule, the capsule is thick, then we put the intra-articular wire for 6 weeks. And we also, if the child is of smaller age, like 12 years or 10 years, so we even apply the plaster. But in adult patients, we ask them to do all the precautions as we do in the total hip replacement. We apply the knee mobilizer, keep the leg in the abduction, and after 6 weeks, we allow them to move. Thank you.
Thank you. Okay, I would like to invite Professor Javed Iqbal on the stage. Okay, so we have the shield presentation too. Yeah. Sir, Professor Amin Chunai, kindly come on the stage. Sir, you also stay here. Okay, sir, this is the shield for the panelist. Sir, yes, Professor Amin Chunai to Professor Javed Iqbal sir. You are the panelist. Okay, sir, be here. नहीं सर 2 मिनट रहे हैं सर, अभी शील्ड्स फर्दर देनी है. ओके, फर्दर पैनलिस्ट में हमारे पास है प्रोफेसर मुहर्रम इनान हैज़ लेफ्ट, प्रोफेसर मोहम्मद बख्श शावानी is not here. Okay, so I will call for the lectures. Professor Irfan Mehboob Saab also left. Sir, Professor Amin Chunai. Yes, now, yeah, no, Professor Javed Iqbal will give this shield to Amin Chunai sir. Okay, I would like to invite Dr. Saeed Ahmed Jadoon to take his shield. Dr. Saeed hai. Okay, now there is a certificate distribution. Okay, for this I would like to invite for a free paper presentation Dr. Muhammad Usama. Sir, आप दें. Dr. Faraz is here. Faraz has left. Okay, And now to Professor Atikuzama. Okay. Now the certificate to moderators, to Dr. Mumtaz Hussain. And now the last certificate, Muhammad Jameen, other side. Thank you, sir. Thank you. Thanks a lot. Okay, thanks for being here. It was very nice sessions, and I think you people have enjoyed well. So our session has completed. Now I think the time is over, and the new session will start in 5 minutes. Okay, thank you.
Look. Bismillahirrahmanirrahim. We start our another session on miscellaneous and the pain. So I would request the panelist, Professor Gulzar Said Saab, to take the seats. Professor Karam Ali Shah Saab, Professor Zulfkar Sumro, Professor Ataur Rahman. I request all the panelists to please have the seats. Dr. Shakil Saab. So we start our first talk from the topic is nanotechnology and biomaterials of orthopedic medical implants. Presenter speaker is Professor Said Farman Ali Shah. I would request Professor Said Farman Ali Shah to please come. मैंने प्रेजेंट आ जाए जी जी सर अच्छा प्लीज
Bismillahirrahmanirrahim. Assalamu alaikum everyone. This may be a very different topic in this whole conference in two ways. That one may be the engineering university, Mehran University of Engineering and Technology, to which I belong. And this may be very rare to participate in conferences specified for the medical, and in ortho maybe this would be a unique collaboration for medical university and engineering university to be at the same platform to be. Actually, I was of the opinion that in orthopedic especially, implants are used, most of the implants used are metallic in their nature, or some composite materials or alloys, they are metallic alloys. But I've gone through literature and recent study and approaches in developed countries where these ortho experts are using the policies and standards of European Union and American standards. And the third one is Japanese. And three of these are found, they are now switching over to the nanomaterials and the biomaterials used for the implants in ortho and packaging and some devices because of certain reasons. These biomaterials, they are used because fabrication of these materials is very easy, and easy in a way that we can make with some natural polymers also. and they are flexible. These alloy materials or alloy metals, they are not flexible at that much level we are observing with these biomaterials. And they are compatible also and having wide range, because in medical or any of the synthetic polymer you are using for the implants, you should think of the range of the material, where we can use, up to what limits we can use, what is the pros and cons of these materials. So range wise they are very much having a wide scope in terms of their properties. Because in usage, you are not looking into the mechanical properties. You are looking into some other properties, electrical, chemical, and thermal properties. And for this biomaterials used for the medical devices and other implants, they are very much useful as compared to other because of their properties. And they are adaptable in the natural fibers, natural tissues, natural repairs, where you need some repairs, and having other material to impart their functionality for the purpose of their body. So they are adaptable. And I've sorted this material from the Biomaterial Science and Engineering 2016, and having citation of 286. And especially for biomaterial, why people refer to nanobiomaterial. Nanobiomaterial are referred or preferred because of their surface area. They have a surface area responsible for the properties which were already discussed. These are achieved because of their areas, surface area, because of this nanomaterial having a minute level to react. So wastage of material is very much minimum as compared to macro materials we are using in experimental or manufacturing of a fabrication. And we can achieve, by using these nano biomaterials, mechanical, optical, magnetic, and chemical properties. These are also achievable because of their smaller size. This is also referred by a very much cited paper, and many of the references were there. I have skipped. You might have experience of these implants more than me, because I'm not of that field. So because of their long-term and short-term usage of these implants, we have our manufacture of fabrication of these implants looking into the use. But for polymers, we are using normally in our medical fields nowadays, we cannot see only as I've come to know about that you can have some thumbnails or some screws which can be used for the temporary purposes, but we can use these for long-term usage of these implants also. And this is only possible in the biomaterials which we are using for the purpose. And manufacturing of these material is also, I don't know why it's not being experienced here in our environment, but in our neighbor and other developed countries, we have a long history of their manufacturing of this biomaterials and nanobiomaterials. And this was a very good reference from the Elsevier and other research papers, having a wide history, their variety of methods and properties, flexible properties we can use in our fabrication and the tissue culturing. Though agriculture has started this tissue culture for the crops, but medicals, they are lacking behind. So I was of the opinion that if we use these biomaterials and especially nano biomaterials, and Mehran University of Engineering and Technology has developed a very good research group of nano technology led by Dr. Zishan Khatri and Biochemical Engineering Laboratory in the Chemical Engineering Department of Mehran University of Engineering and Technology. So this may be a collaboration, and this may be an invitation for the medical people, because in this conference there's a participation from all over the country, I've seen. So we may have a good start of using biomaterial and nanobiomaterial for the implants. Thank you so much.
Thank you so much. For the next talk, I would invite Dr. Amir Gul Memon to come for the presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. Myself, Amir Gul Memon, PhD scholar, working as an assistant professor, Rifa International University, Lahore campus. Today my topic is effects of myofascial release technique with ferritin on pain, range of motion and disability in adults with neck pain. Backgrounds. Major musculoskeletal health issues such as neck and back pain have a considerable impact on both individuals and society worldwide. Frequency of neck pain was 23.1% worldwide, with North America having highest prevalence and Africa having lowest. According to the research, the prevalence of neck pain in Pakistan, generally population has highest 34.7%, with higher prevalence among women and elderly population. In Pakistan, it was discovered that 64% of individuals had experienced neck pain in previous year, with extended sitting posture, bed posture, and lacking of exercise being a main risk factor. Objective: to determine the effects of myofascial technique with ferritin on pain, range of motion, and disability in adults with neck pain. Rationally, Neck pain often results from muscle tension and tight tissues. Myofascial release can help relax these muscles and tension. Additionally, ferritin, a protein that stores iron, is essential for muscle function. The study aims to combine myofascial with ferritin role to tackle the root cause of the neck pain, potentially improving patient's symptoms. Materials and methods. Study design. Control randomized trial was conducted at Umar Atif Clinic and Sulaiman Roshan Medical College Hospital from April 2022 to October 2022 through convenient sampling technique. Total sample was 38 through, calculated by the EP tool. Variable was used range of motion. Inclusion criteria. Adults aged 18 to 35 years, gender both male and female, neck pain lasting for more than 6 weeks, intensity score of 4 or more than on NPRS of 0 to 10. Range of motion limited with score of 6 or less on the NDI. Exclusion criteria: history of neck surgery or injury, inflammatory arthritis, severe congenital neurologically impairments, pregnancy, and lactating women with whiplash injury. Fracture since last 6 months and radiating pain. Intervention: Group A received myofascial release treatment for 3 weeks with 10 minutes hot pack before each session, along with 1 tablet of placebo at the dose of 100 milligram per day. Treatment involved localized selection and examination followed by circular friction with the thumb and palm, moving deeper into the tissue and then release it. This process was repeated 3 times on same spot for 2 to 3 minutes each repetition. Additionally, range of motion was recommended to home program. Same treatment received to the group B or experimental group with 10 minutes hot pack each session, along with the ferritin tablet rate of 100 milligram per day. Additionally, range of motion recommended for home program. Data analysis was used to SPSS 23 version. Statistically, mean Whitney test was used within 2 groups to assess effectiveness of treatment. Ethical consideration was study was conducted after approval of IRB, Sulaiman Roshan Medical College Hospital Management. Informed consent was taken from respondents. The entire study was followed by ERC standard research protocols. Results. Demographic characteristic: majority of subjects were between 26 to 30 years. Most of them were unmarried with normal age, weight, and majority were employed. A table showed that pain and disability score before and after treatment in between and within group. The difference observed in the experimental group compared to control group indicate favorable impact of the treatment intervention on pain and disability. Between and within group analysis of range of motion. All range of motion measures showed a greater difference between and within group in pre and post sessions. These results imply that the MRT, myofascial release with ferritin, had beneficial impact on the cervical range of motion, especially in experimental group. Discussion. Current study showed that the myofascial release has beneficial impact on the improving these patient symptoms. Recent studies conducted in 2017 and 18 suggested that deep friction massage and myofascial release were both effective in reducing discomfort and increase neck movement. However, myofascial release was found in better for the treatment trapezoid or neck pain. Pathophysiology: myofascial release soften and lengthen connective tissues, relieve pain and improving neck mobility. In other study, compare with our findings, myofascial release with iron supplements, experimental group shows more significant to reducing pain and improve functions. Recent study conducted in 2020 combined myofascial release and iron supplementary effectively reduce pain, neck pain and improve neck mobility in women with neck pain and low iron levels. Pathophysiology: iron supplement can elevate neck pain caused by the iron deficiency, while vitamin D supplement can reduce neck pain by regulating muscle activity and lowering the inflammation. Conclusion: study concluded that both groups were potentially beneficial for the decreasing in pain, disability, and enhancing the range of motion. However, the experimental group more significant result in within and between group than control group. Thank you. Any question?
Okay, thank you. So for 3 papers, now I would like to invite Professor Badruddin Saito. His talk is on prevalence of deep vein thrombosis, the lower extremity in hospitalized bedridden orthopedic patients, a pilot study.
Bismillah ar-Rahman ar-Rahim. I am Dr. Waqar Ali, orthopedic resident in Civil Hospital, Karachi. I am presenting on behalf of Dr. Jagdish Kumar, our assistant professor. The paper is the prevalence of the DVT of lower extremity in hospitalized bedridden orthopedic patient, a pilot study. Lower limb DVT is a frequent yet preventable cause of the long-term morbidity and mortality following the major orthopedic surgery. Despite the evidence-based recommendation and available international guidelines, there is no clear documentation of any guideline or protocol at the study site, and more so, the most surgeons often do not prescribe the thromboprophylaxis after the major orthopedic surgery, thinking that the DVT and its complications are uncommon among the Asians, and it is unnecessary to administer the routine anticoagulants to all the patients. At the CHK orthopedic department, 4 patients died sudden a few days after the admission over the 2 months periods in 2021, and all were suspected to be the victim of the fatal pulmonary embolism. On the one hand, we perceive that the DVT and its complications are rare among the Asians, and on the other hand, we claim that the DVT is still the 3rd leading cause of in-hospital death. These observations led us to carry out the current prospective hospital-based cross-sectional study. There are only a few reports on the prevalence of the DVT in Pakistan. However, more recent published reports on the Asian patient challenge that above view and claim that the rates of the hospital-associated DVT and the post-surgical DVT were similar in the Asians and the Western countries. Thus, the current study was planned to be determined objectively the prevalence of the DVT of the lower extremities in bedridden hospitalized orthopedic patients who received no thromboprophylaxis. Our study design was a prospective-based cross-sectional study, and the duration was April 2021 to June 2020, and the location was the Civil Hospital, Karachi. Our study was approved by Institutional Ethics Committee. Informed written consent from the patient who met the inclusion criteria was taken. Inclusion criteria: age 40 or greater than 40 years, admitted for intended major lower limb surgery, expected to confine to the bed for at least 4 days. Exclusion criteria: ambulatory patient, had prior DVT or had been treated with the anticoagulants. The sample size was calculating using the EPI tool, and the confidence interval was 95% and the absolute precision was 5%. The BMI was categorized according to the Asia Pacific classification. Duplex ultrasound of the both legs on the fourth post-admission day was used for screening and the diagnosis of the DVT. A total of 104 patients participated in the study. Among them, the 60 were male and the 44 were the female. The average age was 51.99 years, and according to the Asia Pacific classification, the 5 were obese and the 12 were overweight. Results: the most common type of the fracture was neck of the femur, which was 28, and the 24 patient had IT fractures, and 16 patient had a distal femur, and the 14 had femur shaft fractures, 12 had proximal tibia fracture, and 7 had the pelvic and acetabular fracture, and the 3 had ankle and the foot fractures. 40 patients were admitted within 4 days of the trauma and 64 after the 4th day. The mean delay between the fracture and the admission was 6.4 days. And 29 patients underwent surgery within 7 days of the admission, and 75% had it after the 7 days. And the mean delay between the admission and the surgery was 9.3 days. The mean length of the hospital stay was 12.76 days. Results: the DVT on the 4th post-operative day was detected in 16 patients. Among them, the 10 had an isolated proximal DVT, 3 patients had only isolated distal DVT, and 3 patients had both the proximal and distal DVT. All the 16 patients were asymptomatic, and no suspicion of pulmonary embolism was noted. Discussion: DVT is a silent killer that can kill with little or no warning. Important international guidelines on the DVT emphasize that the prevention is better and cheaper than seeking a remedy after the damage has been done. This is the reference. Data from the randomized control trial assessing the surgical patient suggests that adequate thromboprophylaxis in at-risk patient can prevent the venous thromboembolism in 1 out of 10 patients and save the life for 1 out of 200 patients. Justification of the thromboprophylaxis: the clinical use of the thromboprophylaxis is justified because number 1, in orthopedic trauma patient, all the 3 factors described the Vacho triad are present. 70 to 80% of the such DVTs are asymptomatic, and pulmonary embolism is detected by the perfusion lung scanning in 60% of the patient with documented DVT, even though greater than 50% are silent clinically. Although pulmonary embolism has relatively low prevalence, it is still the 3rd leading cause in hospital death. Finally, 30% of the untreated patients with pulmonary embolism die within the first hours of the event, which does not leave enough time for any conventional treatment to take effect. Limitation: the current study has limitation as it was a single center study with a relatively small sample size. A large multi-center studies are recommended. Also, the study only evaluated the lower extremities, and therefore the cases involving the upper extremity were not assessed. The study used duplex ultrasound when the sensitivity of the venography happens to be higher. Finally, the scanning was done on the 4th day of the admission, and therefore it is possible that late DVTs might have been missed, as a DVT can occur up to the 90 days after the patient has left the hospital. This could be likely the reason for the low DVT prevalence compared to the rates reported from the Western studies. Conclusion: the DVT prevalence was found to be 15.3%, considering that the DVT is a potentially lethal clinical condition that may lead to the sudden death owing to the pulmonary embolism. Routine prophylaxis for the hospitalized at-risk patient on admission, during hospitalization, and even after the discharge is recommended. Thank you.
Sir, thank you so much. Now for the shield presentation to the invited talks, I would request Professor Gulzar Said Saab to please come over the stage and give shield to Mr. Amir. Sir, please you conclude for 2 minutes. I give you mic, sir.
Interesting topics which we have heard. Hello. Sir, first of all, I would like to have a respectable Vice Chancellor from a really pleasant surprise to have you here, sir. And this regarding your topic, nanotechnology and biomaterials of orthopedics and medical implants. I think after 30 years in this field, I regard this as a very important development. But somehow, because of lack of time or something, we couldn't have actually enough knowledge about it. At least I couldn't gather much about it. I just want to ask you 2 questions for that, if you can explain. This nanotechnology and biomaterials, what are the examples? Can we have some examples of those materials, how these are commercially available, where are available, and what are the source of these materials? So, for example, we are very much interested in making them in such a way that it should be cost effective. And as we are using these in orthopedics, so in orthopedics we have, a lot of weight transmission on that. Those materials are able to sustain the pressures of locomotion and all that, and how much stress and strain is possible with that, and from what are the examples and from where we can get this.
Thank you very much, and that was very surprising to me that after 30 years of experience you are having such information. But I'm of the opinion and having references there, and that this is manufactured and strength-wise, tensile strength and compressive strength is equal to the synthetic polymers we are having with from you are using in steel and other materials. So they are equally strong in both of the strength, as the compressive and the tensile strength. So they may be used. And for manufacture, the Japanese and European Union, they have started, and I have visited one university in Cologne near Bonn, Germany. They are having this manufacture at a smaller scale, but we can start with our own resources from natural sources of polymers we can make. And I have quoted these 2 laboratories in Mehran University. One is this nano group led by Dr. Khatri, Zishan Khatri, and he has postdoc and other researchers experience in Japan, good universities. Other laboratories, biochemical engineering laboratory in Mehran University, they are also having good laboratories. They can help in the tissue culture and the manufacture of them.
Thank you very much, sir. One comment about Dr. Amir Gul Mehman. It was really interesting. I can tell you, every day we are facing this problem of neck pain and all that. And it is really good information that ferritin, if you give ferritin along with that physiotherapy, it will work wonder in relieving that pain. The simple comment is that as an orthopedic surgeons, we have to find out the cause of that pain as well. And many times, if you don't relieve a cause, for example, some disc herniation causing pain in the neck, or you have some disease like, for example, tuberculosis or some infection, or other pathological conditions which are actually initiating this pain do need attention, right? Sato Saab, very good. I mean, who can actually deny this importance of that looking for the DVT in the bedridden patients in our country? It is of course very important to have the awareness regarding this DVT, and treating them, even prophylaxis is now recommended nowadays. Thank you very much. It has been wonderful, but it is unfortunate that we have 6 speakers missing. I know they should be caught and handed over to. Thank you.
Thank you so much, sir. It was, these were quite different topics, but very interesting topics, and they have great importance. Sir, now for the presentation of the shields, I would request Professor Gulzar Said Saab and Professor Karam Ali Shah Saab to please come forward on the stage and give the shields to the speakers. First of all, for receiving the shield, I would invite Dr. Amir Gul Memon to please come and receive the shield from the panelists. I would request Professor Syed Farman Ali Shah to please come forward and receive the shield from the panelists. Certificate done. For free paper presentation, I request behalf of Dr. Badruddin, Dr. Wakar to receive the certificate from panelists. I would request Professor Dr. Gulzar Said to give shield to Professor Karam Ali Shah Saab. I would request Professor Karam Ali Shah Saab to give shield to Sir Gulzar Said Saab. Sir, thank you so much. Please have the seats. We are very much thankful to you. We are thankful to all the presenters, speakers, and our session ends over here. Thank you so much. Panju, moderator? Sir, please, you are kindly requested to please come and give certificates to the moderators.
So Dr. Najeeb Ahmed Kalo, please come on the stage, collect your certificate. And me, Dr. Shakil Ahmed.
एक्चुअली मैं बेसिकली फ़िज़ियोथेरापिस्ट हूँ, ठीक है, और मेरी ग्रेजुएशन लियाकत यूनिवर्सिटी जामशोरा से है और मास्टर इस्लामाबाद रिफा इंटरनेशनल यूनिवर्सिटी से, और अभी मैं पीएचडी कर रहा हूँ मलेशिया से, ठीक है। तो कल एक रिसर्च स्टार्टअप के नाम से एक वो इनिशिएट है, उसमें मेरा एक प्रपोज़ल है। मैं चाहता हूँ कि आप लोग सारे उसमें आएँ, क्योंकि वो बेसिकली ऑस्टियोआर्थराइटिस से रिलेटेड है, जिसमें मैं एक डिवाइस प्रेजेंट करना चाहता हूं, और वो गेट एनालाइज करके हम किसी भी पेशेंट को ऑस्टियोआर्थराइटिस ग्रेड 1, 2, 3 उनकी डिफरेंट ट्रीटमेंट फिजियोथेरापी और फार्मेसी, जिसमें ग्लूसामिन और फिजियोथेरापी दोनों का कंबाइन इफ़ेक्ट्स देखना चाहते हैं। 3 अलग ग्रुप बना के, जिसमें एक को दोनों कंबाइन देंगे, एक को सिर्फ फिजियोथेरापी देंगे और थर्ड को हम ग्लूसामिन देंगे। लेकिन ये सारा पहले हम गेट एनालाइज करेंगे, उसके बाद देखेंगे कि कौन से मसल्स उनके वीक हैं, उसके बाद हम उसके लिए उस तरह की ट्रीटमेंट या उस तरह की रिहेबिलिटेशन प्रोटोकॉल बनाएंगे। तो अब मैं चाहता हूँ कि आप लोग सुबह 9:30 बजे इंशाल्लाह, ठीक है? थैंक यू सर।
Thank you so much.
The universe is in